However, he comes back to us 2 days later with persistence of his initial presenting complaints, but his cough is now worse, still non-productive, but he's finding it difficult to breathe, both from a tightness of his chest and also shortness of breath associated with the coughing. He now has even more pronounced anorexia. He's lost his appetite completely, still no other GI symptoms, and still no new complaints other than as noted above. His examination continues to demonstrate a highly febrile adult male who is still tachycardic, even more tachypnic, and now, without even changing his medications, his blood pressure, if anything, is low. So we now have a patient who has become hypotensive, which is definitely a cause of concern. This time, we remember to do our spot check for his peripheral oxygenation, and indeed, he has an oxygenation of only 89% on room air. This is cause for concern, regardless of the viral etiology, but certainly, if we're considering COVID-19, this would be a trigger for us to do further evaluation and further intervention. His chest exam now demonstrates diffuse fine crackles bilaterally. His air entry is adequate but not great, and he does show increased work of breathing. The rest of his exam, however, is unchanged. So again, what should leap out at us is the worsening of symptoms, especially the cough, the development of shortness of breath, and an associated decreased peripheral oxygenation of less than 90%. These are two red flags for COVID-19 suspect patients that would significantly suggest a need to do further intervention and further evaluation. Similarly, he now has evidence of hypotension, which could be a complication of advancing COVID-19 or of potentially a superinfection from a viral etiology with a bacterial sepsis. So, long story short, Mr. Lecturio has got our concern, our interest, and we need to consider what to do next. So, what are next steps in the assessment? If we haven't already, we'll certainly wish to evaluate for other viral etiologies and consider now testing for COVID-19. Given the, again, fairly non-specific nature of the presentation for all of these, Mr. Lecturio could still have any one of the etiologies you see listed on the screen in front of you. Any of the influenzas, parainfluenza, rhinovirus, coronavirus, COVID-19 disease, anything else. What are the next steps? Do we now consider testing? What do we do next? And in fact, we may wish to consider doing blood testing along with testing specifically for COVID-19 and also considering imaging. What are we going to see with these in the setting of COVID-19? CBC, we're looking especially for either a normal or potentially reduced peripheral white blood cell count, so leukopenia, along with a lymphopenia, reduced percentage of lymphocytes, and maybe even in some cases, about 40% so far, thrombocytopenia, decreased platelet count. The inflammatory markers, we're looking to see an elevated C-reactive protein or creatine kinase, an elevated lactate dehydrogenase, something to suggest that there is cytokine storm and or inflammatory burst occurring, as these are highly associated with advancing disease in COVID-19. Organ function, we absolutely want to see where his kidneys are at, where his liver is at, where his heart is at. So doing a comprehensive metabolic panel to include signs of or indicators of urine function, liver numbers, and then ascending cardiac enzymes, all of which are indicated. Doing a blood gas if we want to confirm our lower peripheral oxygenation and see is he indeed failing to exchange oxygen and carbon dioxide. What is his pH? Do we have respiratory acidosis, alkalosis, etc.? Sending a blood culture. Well, yes, because even if this were COVID-19 or other viral etiologies, there still could be the potential of a secondary bacterial infection. Yes, we want to consider COVID-19 testing because we now wish to do further emergent care. Mr. Lecturio requires help, and we need to know if he is a suspect patient. Then imaging, considering chest radiograph versus computed tomography or CT scan. Of the two, the CT scan will be more specific and sensitive for findings that we wish to demonstrate in the setting of COVID-19. Chest radiograph, however, is easier to obtain, easier to perform, and thus may be the first step while we're contacting the radiology suite to get our next set of testing. So in this case, with the anticipated results as we just discussed, Mr. Lecturio's results start to come back. And indeed, his complete blood count shows a low white blood cell count of 2.7 or 2,700 cells per cubic millimeter, with 67% neutrophils, 25% lymphocytes, and 5% monocytes. So indeed, he now is leukopenic and definitely lymphopenic. His hemoglobin and hematocrit are normal, but he is thrombocytopenic at 85,000. His inflammatory markers demonstrate slight elevation of the C-reactive protein with 4.7, normal being less than 3, and his lactate dehydrogenase is also slightly elevated at 360. Moving on then to his organ function, indeed he shows evidence of some early renal insufficiency with a slightly elevated blood urea nitrogen of 24 and an elevated creatinine of 1.4 milligrams per deciliter. In addition, his transaminases, AST and ALT, are 85 and 79 respectively, although his total bilirubin is normal, and his troponin I is slightly elevated at 0.5 nanograms per milliliter. So he has evidence of mild multi-organ disease, which would go along with potentially invasive bacterial sepsis, a SIRS, like systemic inflammatory response syndrome, but also with multi-organ dysfunction syndrome, which can be seen with more advanced or severe COVID-19 disease. His blood gas, obtained from an arterial source, shows a slightly elevated pH of 7.47, a low partial pressure O2 of 55 millimeters mercury, partial pressure CO2 of 32 millimeters mercury, and his bicarb, HCO3, is in the normal range of 25 millimoles per liter. But then and again, his peripheral oxygenation is low now at 87%. Blood culture. Yes, a blood culture is sent in this case to look for bacterial superinfection or pathogens and is negative at 48 hours, which suggests, it doesn't exclude, but it does suggest that there is no bacterial superinfection at this stage. Chest radiograph indeed was performed just because it was easier and faster to obtain, and it showed the typical non-specific bilateral infrahilar air space opacities, which could be seen with any viral process or even non-specific atelectatic changes. However, there's no evidence of increased fluid because the costovertebral angles are clear. A chest CT scan, though, does demonstrate bilateral nodules and the expected peripheral ground glass opacities throughout the lung fields, as well as some mild intralobular septal thickening. All of these can be seen in COVID-19 disease and also to a significant extent in acute respiratory distress syndrome, ARDS, caused by a variety of pathogens. So where we're at then, what are the ultimate diagnoses? In Mr. Lecturio's case, rapid testing for influenza came back negative, as did molecular diagnostics for other respiratory virus panels. This doesn't not completely exclude those diseases, but it makes them less likely. However, his nucleic amplification assay is positive for the SARS coronavirus 2, the cause of COVID-19. So we can make a strong presumptive diagnosis of COVID-19, knowing, however, that co-infection is still possible, especially with influenza and also potentially bacterial superinfection. So this case presentation shows a typical progression and typical findings for an advanced case of COVID-19, however, which began with mild disease. And you can see, at least I hope you can see, that it's very difficult to differentiate COVID-19 caused by SARS coronavirus 2 from other viral pathogens causing upper and lower respiratory tract infections. However, hopefully this case is instructive in looking at how a patient may progress and ultimately come to medical attention and deserve further evaluation. Now, looking specifically again at what I've shared with you with Mr. Lecturio, what is his risk of critical disease? Looking at his age 62. Well, so an age of 65 has been looked at as a strong cutoff above which risk of critical disease is quite significant. However, the risk begins to escalate even in the late 20s. So age 62 would be a moderate risk factor for risk of critical disease. However, and specific to this case, Mr. Lecturio does have two comorbidities, that being hypertension and diabetes mellitus, both of which increases risk for severe disease. Further, when he represented to us the second time, the peripheral oxygenation was less than 93%. he also had elevations of his transaminases and a worsening of his renal function. So he has multi-organ dysfunction, some hypotension, definitely a difficulty in air exchange and oxygenation, and an impending hypoxic respiratory failure. So Mr. Lecturio's risk of critical disease is actually quite extensive, and this case would suggest one who definitely deserves hospitalization, close monitoring, and further support as necessary. So to wrap things up, starting from a mild, non-specific illness, yet with risk factors which we've identified, and also with comorbidities, this case shows a very unfortunate but typical progression into much more severe critical disease, along the way being differentiated from other viral pathogens which may contribute to or cause instead of the disease which we're looking at as caused by COVID-19.